this might take, and
Sure.
how long?
The procedure itself actually doesn't take that long. Here, let me just draw a turn. It usually takes under an hour or so, but it's the anesthesia getting you to sleep and then waking you up at the end of the procedure. When you add that all together, you're adding about 45 minutes on either side. So you should plan on maybe 3 or plus hours for everything. Okay, 3, maybe 4 hours. If it takes a little longer, I wouldn't fret. You know, we just need to do whatever it takes to get the job done right. Okay.
Okay.
You would be in the intensive care unit overnight. You'd be laying flat, and the reason why is when we let the blood out, air gets in. Come an airhead, literally. And for the air to clear, it actually works better if your head is flat. Just in terms of the dynamics, so the air can slowly escape, and your brain equilibrates with the environment. Okay? That drain will stay in overnight, and then tomorrow the drain comes out, and we'll start to slowly begin to sit you up the next day, and then get you up and around the day following, and hopefully out of here. Okay?
Okay.
And what was the final word about the Plavix resumption? Because I was feeling not very comfortable with the Plavix.
Well, I agree with
being
you,
on
and
Plavix
I'm not going to go
long-term.
back on it until I see the cardiologist.
Okay. Well, that's fine. I think that personally, I'd probably start you on aspirin in a couple weeks after surgery for heart reasons, for your blood vessel reasons. But again, any antiplatelet agent like Plavix or even aspirin, which is a much weaker one, does put you at additional risk for bleeds. I just think that with the heart risk and the peripheral vascular risk, most likely you should be on some kind of antiplatelet agent long term, maybe not Plavix. Okay, that makes sense?
Yeah.
So my recommendation will probably be, will be to start aspirin at 2 weeks. And I'd see you in clinic at that time with a repeat scan. Let's see here. So this was on July 7th. Let's see, he's got more recent imaging.
Okay, thank
If you
you.
could see this again, just to review. Try to turn this a little bit. So on the right side here, if I window it correctly, you can see that this is where the brain is. The brain is here on the, and then there's this fluid collection here. Okay. It should also be for craniotomy. So my plan is to make a small strip shave along here and drill 2 small holes and try and evacuate the fluid. Now, if I do not think I can safely get out the fluid from just 2 holes, I would recommend doing, at that time while you're asleep, doing what's called a craniotomy. I think I discussed this with you, is that correct? Where I then connect those incisions and then take a small window of bone like this. That will help me open up, get inside, and clear out that fluid collection much more definitively. The downside of that is it probably adds another hour, hour and a half to the procedure. But I think that if we're going to do a surgery, we ought to do it right the first time around. And if I don't feel I can safely do it with burr holes, that's what I would do. And it would be a safe procedure to do. It just is something that we won't know until we get there. My preference, as always, is to do the minimum surgery required to get things done and you treat it safely. All right? And if I feel that I can safely evacuate as much of that blood as possible through burr holes, that's how we'll proceed. Otherwise, I think I've already explained to you the hospital course. With regard to risks, we talked about those as well. There is a 20% chance of recurrence even if we do a burr hole procedure. Most likely, we try and avoid doing repeat surgery if at all possible. But if it was a substantial enough accumulation, I'd talk to you and say, you know, this is what I recommend. Serious or life-threatening complications about 5%, and that includes mainly anesthesia risks, heart risk, lung risk, okay? But from a procedure standpoint, the main risks are bleeding, which may require reoperation, injury to the brain, which can cause stroke-like symptoms, weakness, paralysis, coma. In the worst situations, even death. I think altogether the benefits clearly outweigh the risks. You have a large subdural hematoma and one that is unlikely to just go away by itself. It's that large, and you've had symptoms from it. So, like I told you, if you were my own family member, I'd recommend a Burr-Hole procedure. Okay?
Okay.
Questions?
I'm letting you make the decision, sir.
Well,
I
no,
don't know
no.
what you want.
You're in the driver's seat, and I know we've talked about this before, but I want to make sure that all your questions were answered.
Now, how long will I be down after this is over with? When I say down, as far as doing anything, coughing.
Maybe, I'd say a couple weeks.
Okay.
I'd like to see you back before we, get you cleared for, no restriction on activity. But if we're going to restart you on aspirin, I'd like to get a CAT scan at 2 weeks, see how things are at, and then rescan you again at 6 weeks after surgery. So you're a little bit more, closely followed than the usual Burr-Hole patient, but it's because I want to put you back on blood thinners, antiplatelet agents, okay?
Okay.
And what did you say the hospital stay is typically for this?
Probably about 2 days. So 1 day in the ICU, the next day in the ICU to the floor, 2, maybe 3 days.
That's not bad.
That's my feeling. And my whole goal with all of this is to get you back to doing what you normally do, get you off of Keppra, the anti-seizure medication, after a month. All right? And ultimately, there'll be no restrictions for you. All right? Okay. Well, here's the consent form. And this is there's a separate consent form for blood transfusion if necessary to save your life. Is that something you would assent to?
Yes.
Okay.
My name's Bernice.
It's highly unlikely you need a blood transfusion, but I want to make sure all avenues are covered.
Couple questions, go over some things. Can't take you right now until I'll start
Okay. If you agree, the first sheet is procedure for the right-sided burr holes and possible craniotomy. The risks are as I described here. And if you agree, I just need you to sign. Today is the 14th. You also sign that. Sorry. Where do you folks live?
Manassas.
What I will do is, as soon as we're done in the operating room, I'll go out and talk to you folks and just tell you, make sure that you know that the operation's done, everything went fine, okay? So I'll come get you.
Since the last time we saw you, no fevers, no chills, no chest pain, no problems, no, nothing new. No, okay, good. No changes.
I've had a little itching, but I think it sounds like maybe one of the medications or.
Itching? Yeah. Hopefully we won't need to cancel surgery for itching.
Unless you're
No,
covered,
nothing
yeah.
else.
Well, it depends how bad the itch
How
is,
bad,
actually.
yeah.
All right, very good. I'll see you.
Okay, Doc.
And I'll speak to you folks in just a little bit.
Thank you.
Thank you.